Sir, thank you. Good morning, everybody. I hope it's okay for you if I speak in English. It's a relatively complicated topic. As you will see, we are talking about rare diseases, and I think else we could stay until tomorrow if I speak in German, so I will do it in English. So there are two main types of liver vascular malformation, and these are congenital portosystemic shunts and hereditary hemorrhagic telangiectasia, and we will go through them separately. So first of all, congenital portosystemic shunt are congenital malformation that result from the incomplete involution of one or several early embryonic or fetal vessels that are present during fetal life or after birth for the ductus venosus. They are important to know, so to recognize, because especially in children, they can cause complication due to the diversion of the portal venous flow into the systemic vessels. In adults, we will see that they are often an accidental finding, and in this population, it is important to remind that they should be differentiated by portosystemic collaterals due to portal hypertension in the context of chronic liver disease. I will, of course, not go into detail, but I think it's nice to remember that the liver develops in the context of a very, very large vascularization. So the liver is a vascular organ indeed, and during the 4th to 6 weeks of gestation, take a look to the big transformation that happens. You can see that early there is a venous sinus and two vitelline veins, right and left umbilical veins that little by little transform and have an involution, and later on just a portal vein remains from the vitelline vein additionally to the left umbilical vein that closes later on in life, and from the umbilical veins in the venous sinus, the liver veins and sinusoids are formed. So it's a very complex anatomy that, of course, can have congenital malformation, and these are what we will see in the next few slides. Let's start with the intrahepatic portosystemic shunts. So remind, the first thing is to locate the shunts. Is it in the liver or outside the liver? And this makes a lot of differences. So we will see that intrahepatic portosystemic shunts are classified according to this classification that is shown here. It's Park's classification, and you can see that it's relatively simple. You have to locate which vein of the liver veins is the drainage point of the shunt, and which is the branch of the portal vein intrahepatic that is the initial pathway to the shunt. So, for instance, type 1 is from the middle liver vein, so from the right hepatic vein, right portal vein to the middle hepatic vein. Type 3, which is relatively common, is from the main portal vein or in the bifurcation intrahepatic to the right hepatic vein, and so forth. There are, of course, conditions that are not straightforward and are complex. These are type 4, and sometimes there are even more complex malformation involving also arteries. These are, however, really quite rare, and we will not go through them. So these are rare situations, 1 in 30,000 to 1 in 50,000 live births. There is a registry in Europe and worldwide to try to track what is the follow-up of this. Usually is, however, an accidental finding on ultrasound or imaging, and even in children nowadays, since ultrasound is now a very standard technique used already also before the birth of children, these can be very easily and very early diagnosed. Many of them are completely asymptomatic. In particular, if we see them in adults, usually it's an accidental finding without any major complication. However, there are some complications or some manifestations, and up to 30% of these adults have minimal increase in transaminases or cholestasis. In case of large shunts, you can see some hemolysis, so due to intra-shunt hemolysis, and some minimal increase in ammonia that show indeed that there is a portosystemic shunting. Only in very rare cases, this can lead to chronic or episodic hepatic encephalopathy, and this tends to be more common in aging, so in older elderly people due to involution a bit of the brain that is permissive to the development of hepatic encephalopathy. Treatment is usually known exactly because patients are asymptomatic, but in symptomatic cases with encephalopathy, what we do is to treat encephalopathy exactly as in liver cirrhosis with the same medical therapy, and only in very, very selected cases one can discuss with interventional radiology to close the intrahepatic shunt, but this is really restricted to a minority. It's a bit different in children because, as you can guess, there can be complication in children. And in children, usually there is a decision to close the shunt early in life to try to avoid retardation of growth. But we will stick to adult patients because this is what we see. This is a case we observe in our department. You can see that the patient was completely asymptomatic, and in an ultrasound, it was seen that there was a strange structure. You can see from the portal vein, this is the liver vein that is dilated, and you can see a rounded structure close to the gallbladder, which is the shunt, and how we confirm it is with color Doppler and post Doppler. You can see that the shunt has a yin-yang, so blue and red color, because it receives blood from the portal vein and the blood gets away from the shunt into an enlarged liver vein, and this is how we confirm it. But much more important is the other situation, which is what we call congenital extrahepatic portocaval shunt, which in the past was called Abernethy malformation. And of course, many of us still refer to this term. John Abernethy was a surgeon, worked in London in the early 19th century, and he described the absence of the portal vein associated with congenital mesocaval shunt. And nowadays, we refer to this malformation as a malformation characterized by hepatofugal flow associated with a congenital extrahepatic portosystemic shunt, either side to side or end to side. It's a very, very rare disease, and what is important for all of us to remind is that in type 1, we will see in a moment how it is classified. The vast majority of cases are associated with other type of malformations, and the most common ones are cardiac malformation. If you see a patient with a lacking portal vein and a large portocaval shunt, plus other type of malformation or syndromic situation or chromosomic alteration, please think about Abernethy transformation. And this is the standard classification of extrahepatic portosystemic shunts or portocaval shunts. Type 1, according to Morgan and Superina, is the absence of intrahepatic portal vein associated to this shunting situation, and we have a type 1A, where the mesenteric vein and the splenic vein separately drain into the vena cava, and we have a subtype 1B, where superior mesenteric vein and splenic vein create a portal vein, but the portal vein then does not go into the liver, it goes directly into the vena cava. It's very important, and we will see it later on, to discriminate between type 1, which is complete absence of intrahepatic portal vein, from type 2, where microscopically at least there is some intrahepatic portal vein remnants. And this is the schematic the representation. You can see the type 1, where splenic vein and superior mesenteric vein go into the vena cava separately. Type 1B, where both create a portal vein that, however, goes into the cava without going into the liver. And type 2, where even if you do not see them, but the portal vein gets into the liver and has microscopically then some remnant. This is a case of type 1B. You can see both the splenic vein and the superior mesenteric vein get into a somehow portal vein, but the portal vein gets directly into the vena cava inferior. It's important to know that these cases do not have portal hypertension, so you do not see splenomegaly or its complications. There is another type of classification which sometimes is used, that is according to the outflow type. You can see that type A is the drainage into the suprahepatic part of the vena cava. The type B is a drainage into the left or right renal veins, and type C, which is rare, is drainage into the iliac vein. And this is a very nice image published showing a type C, which is very, very rare. You can see that there is an enlarged inferior mesenteric vein that goes into a right iliac vein. And this is important also to our colleague of gastroenterology, because this often leads to congestion of the intestine and then lower gastrointestinal bleeding. Clinical presentation, first of all, when you have your patients in front of you, think that if you have a man in front of you, it's more commonly a type 2, because type 1, which is complete absence of the portal vein in the liver, is more common in female. And this is the type that is often associated with also other type of malformations, such as congenital heart defects, polysplenia, and malrotation of other organs. The most common symptom in childhood is hyperammonemia associated with growth retardation, but there are many children and many adults then that you can observe in life that have no severe symptom presentation, and again, it can have just correlate with imaging. So this is not a straightforward diagnosis. It's, however, almost invariably associated later in life to some long-term consequences. So it's not a benign situation. And these are the symptoms or the characteristics that can have later in life. Encephalopathy can happen later in life, usually starting from an age of 20, 30 years old. We can have an association with portopulmonary hypertension, because shunting per se, even unrelated to portal hypertension, can create a situation of mismatch of vascular resistance and then pulmonary hypertension. And what we can very, very often see are focal liver lesions. The majority of them are benign, but some of them are not benign, and we will see that there is some risk of hepatocellular carcinoma with beta-catenin mutation in male subjects in particular. What we should do whenever there is one of these situations and we do not see an intrahepatic portal vein is to characterize the anatomy, and this is quite obvious. CT scan with angiophase is the recommended way of better understanding the anatomy. But then, as a pathologist and as specialists, we should be thinking of whether this is really a type 1 malformation, so no portal vein at all in the liver, or a type 2 malformation where microscopically there are portal venules. And this is not trivial. It needs to be done on biopsy, and this information cannot be obtained by any other imaging technique. And why it is important, this is just an example. You can see up left that there is no portal vein at all in the portal tract on biopsy. You can see very large arteries, you can see some fibrous tissue, but there is no portal vein remnant at all. However, in the lower right part, you can see that there are minimal, small, atrophic portal veins. These are the small structure indicated by the arrows, and even this minimal portal vein indicates that this is a type 2 malformation. And why it is important is that the type of therapy will differ, and we will see in a moment. In addition to this, what in some specialist center is recommended is to quantify the shunt. This is particularly important in children because over 60% of shunt through the malformation increases the risk of hepatic encephalopathy. And we will see that if it is in a type 1 malformation, it is already indicating that this patient likely will need a liver transplantation. Clinical management depends on what you are seeing, and again, on clinical complications. Complications mostly are encephalopathy, as we said, and in children, growth retardations. There can be other, but we will not go through them. The important thing is to look at the biopsy, and we will go through that. In mild forms, the most important aspect to be considered are focal liver lesions. And in focal liver lesion, we should go on, as we do also in cirrhosis, knowing, however, that the absence of a portal venous flow modifies the aspect on magnetic resonance different phases. And so here, what is important is whether there is a T1 hypointensity in MRI, and if the lesion has this aspect, there is already a suspicion of malignancy, and these lesions require liver biopsy. So why it is so important to classify the type of malformation is because in type 1, we have no way of improving the perfusion of the liver. So if in case there is hepatic encephalopathy or liver failure, the only treatment we can offer to our patient is liver transplantation. And I will not enter into the complexity of the surgical part. This can be done by one of our colleagues of surgery later on. But of course, liver transplantation is the only thing we can do. In type 2, if we have microscopic portal veins, we can try, at least in children, to restore an hepatopetal portal flow by closing the shunt. And closing the shunt can be done in a different way, by embolization in some cases, and in other cases by surgical bending, followed by an occlusion. It's complex, but it can be attempted if microscopically there are portal veins in the liver. Of course, if it's not effective, liver transplantation remains a valid option. There are several cases described in the literature of closing of the shunt. We have in Switzerland one of the best experts in this type of malformation, who is Valerie McLean. So in children, we always refer to her cases that are complex. Remind, however, that closing a shunt is a very complex interventional radiology procedure, followed by a significant risk of portal hypertension in those patients who have already increased resistances in the liver, so it needs to be taken into account, and it can be followed by thrombosis, and therefore these patients require anticoagulation after coiling, or like in this case, closing the shunt with a large implant, which is similar to what the cardiologists do to close the patent foramen ovale. This is the therapeutic algorithm, just as a summary. Remind, if it is a type 1, the only therapy we can offer is liver transplantation in severely symptomatic cases. If the patient is asymptomatic, follow-up is the right thing. In type 2, we can consider closure of the shunt, or later on liver transplantation in case of ineffective treatment. Liver transplantation in these children has good outcomes. This is what has been reported by the literature. The majority of transplants performed in the literature are in children. There are, however, some reports also in adults, and we have our own patients transplanted for this indication. And the vast majority do not develop very severe complications, in particular if you take a look to the most recent literature. Thrombosis is a matter also here, so a course of preventive or prophylactic anticoagulation after transplant should be considered. This is a case I wanted to show you because it's a case of our own, observed our center. It was in September 2019. It was a female patient, and remind what we said before about prevalence. So female patient, 34, Turner syndrome. She was sent to us because she was found to have a liver lesion or multiple liver lesion with cavernous transformation of the portal vein. This is what was said to us. And also in our first ultrasound, this was interpreted as a chronic portal vein thrombosis. However, we said there is not really a cavernoma. It's a portal vein is thrombosed and chronically fibrotic, but no cavernoma. Plus, in our ultrasound, we diagnosed a horseshoe kidney, so another malformation. The liver was normal, so no fibrosis, no portal hypertension, the spleen was normal. In the Doppler ultrasound, no sign at all of a venous, of a portal venous flow. The confluence was open, and we saw in the other vessels a sort of hepatopetal flow, so in the direction of the liver, but no portal vein at all. We saw this hypoechogenic focal liver lesion in segment 4, and the lesion on contrast-enhanced ultrasound showed a quick hypervascularization. Remind, however, that this liver is only vascularized by the artery, so we cannot talk about a hypervascular behavior. It's a arterial vascular behavior. In the arterial phase was that, and in the late phase, it is the only phase we have because there is no portal venous flow. There was a late and mild washout. So we postulated adenomas. These were confirmed. But when we did the angio-CT for the adenomas, we saw this. And you can see up is the vena cava. I will run it again because maybe it's not so easy. This is the mesenteric vein. You can see that it goes up to the vena cava. So this was a Abernethy malformation type likely 1. We could not say before having the histology, but it's a type 1. And as for the outflow, is a type A because the superior mesenteric vein and splenic vein drain into the vena cava in its suprahepatic part. And she was transplanted successfully, she went well, and then remind what we said about cardiac and vascular malformation. The patient last year developed a spontaneous dissection of the aorta that has been repaired, but I think this really fits into a diagnosis of a type 1 Abernethy. These are my take-home messages for this part. Remind important where the shunt is, how large the shunt is. The main complications are the pulmonary complication, focal liver lesion, and hepatic encephalopathy, and then try to classify the type of Abernethy, not only on imaging, but also with a liver biopsy, if not at all, if you cannot go further with imaging. Then we shift to the second part, which is hereditary hemorrhagic telangiectasia, which is a very fascinating disease, first described by Dr. Babington in 1865 in this simple letter to the Lancet that was hereditary epistaxis. So it showed how there was a family affected by this important and severe epistaxis. The syndrome or the disease was much better than described by these 3 physicians, one French, one Canadian, and one English physicians that described the classical manifestation. Later on, inherited disease of inadequate vessel with liver involvement, and the first series was published in 1907 by Weber. And this is why the disease is also called after Randall Osler Weber. But we now call it with this proper name, hereditary hemorrhagic telangiectasia, HHT. This is an autosomal dominant disorder due to a monoallelic mutation that occurs in 1 to 5,000 to 1 to 8,000 people, characterized by mucocutaneous and or visceral vascular malformation, which range from telangiectasia to large arteriovenous malformation. And it's important to know that even in families that are affected, the penetrance and phenotypic expression are very variable. We need to know a bit of genetics to understand HHT. So there are 3 major types of the disease characterized by mutation in different genes. Important to know is that these genes codify for proteins that are involved in the transforming growth factor beta receptor complex or cascade, and we will see that this is a pathway that is involved in stopping angiogenesis. So if you have a mutation in one of these genes, you will end up with a non-controlled and activated angiogenesis through the VEGF pathway. Liver is not involved in every patient, it's involved in a bit more than the half of the patient, and the majority of cases belong to HHT type 2, which is activin A receptor like 1 mutations. I will, of course, not go into the details, but there are very nice reviews if you are interested that look into the biology of the disease. These proteins really go at the end into activation at the target gene regulation in the TGF-beta pathway, and you can see that TGF-beta is the responsible, in this case, of maintaining quiescence of vascular biology. And if it stops working properly, the VEGF pathway gets activated permanently, and this leads to increased survival and permeability of endothelial cells, proliferation of endothelial cells, and migration of endothelial cells. And phenotypically, this is what we see. We see telangiectasias in the peripheric, in the skin and the mucosas. We have epistaxis, that is typically the first manifestation leading to the presentation of patients, and we can have visceral lesions plus a family history. These are the so-called Curaçao criteria. If 3 of these criteria are present, the diagnosis is sure, is definite, and if there are 2, it is likely. If less than 2, it is unlikely, and we can rule out the disease. This means that if you have a Clinical diagnosis, you should not stop, and you should be very, very systematic in looking at the target organs that can have complication or malformations. And you should take imaging of the brain, of the lung, make a screening of the with Doppler of the liver involvement, and we will see this in a moment. You should check also the gastrointestinal tract for malformations, vascular malformation, and also for possible polyps. And you should avoid having anemia, and this has to be screened properly. These are just two examples of a large arteriovenous malformation of the lung and another one in the brain. And as you can guess, if you have a malformation in the lung or a large arteriovenous malformation in the liver, this is permissive to other complications, such as, for instance, infections, because the liver will not filter sufficiently the pathogens coming by the intestine, and or if you develop a thrombosis in the peripheric vein and you have a large arteriovenous shunt in the lung, this can lead to paradoxic embolism with stroke. So it's extremely important to screen for all the possible involvement of other organs. The liver is our organ, and we will look a bit into it. The spectrum of malformations is very variable, so you can have minimal telangiectasia that you can visualize as spots with some Doppler in Doppler ultrasound to large arteriovenous malformation. And this is something that occurs with very mild fibrosis and usually a completely normal health, hepatocytes and liver parenchyma. The malformation can occur at any level, so from the hepatic artery to the portal vein, from the portal vein to the hepatic vein, and from the hepatic artery to the hepatic vein. And this can lead to different types of complications. If it is mostly in the portal vein, it will lead to portal hypertension, which is not very common, but very severe when it happens. If it is into the hepatic vein, of course, it's shunting, and so you will have hepatic encephalopathy. And if the malformation is, of course, mostly between the hepatic artery and the hepatic veins, you can have the most important and severe complication, which is heart failure due to high cardiac output due to this extreme amount of blood reaching the heart through this shunting. Mesenteric stele, so you can have then aspect like intestinal ischemia or liver ischemia, and biliary ischemia is something that can happen due to stealing. We screen for this type of involvement through Doppler ultrasound. This is so-called Buscarini classification. It's a very simple one, and those of you who do ultrasound should know that to diagnose liver involvement in HST, you should not look at the liver, you should look at the hepatic artery, because if there is shunting, even if just light or mild, the hepatic artery will compensate through a dilatation. So you see an increase in size in its diameter, an increase in peak velocity, and decrease of resistance index due to low resistances. And there is a classification. I will not go through that, but just to let you know, it's relatively easy to do this diagnosis if you are a bit experienced in ultrasound. You see here a grade 3 already liver vascular malformation in HAT with very high velocity of the hepatic artery, 3 meters per second, and clear shunts between all the vessels in the liver, a lot of vessels. And this is a so-called grade 4 or decompensated shunts in HHT, where you can see already signs of a large dilatation of the hepatic veins as a consequence of heart congestion. If you have an histology, which we never do, but only in very selected cases after transplantation, you can have it. What you would see is a lot of dilatation of sinusoid, and you can even see the arteriovenous malformation. Remind, malformations are everywhere, not just between artery and vein, also between veins and artery and portal vein. You can have focal liver lesion as in any case of mismatch between portal venous flow and arterial venous flow and shunting. We talked about it before in Abernethy. This is a bit the same in HHT. The majority of lesions are benign and are FNH-like in Budd-Chiari syndrome, but there are adenomas that have been described, and rarely, if there is also some other additional feature of liver damage, such as alcohol, you can have HCC. This is a patient of us that developed ischemia of the biliary ducts. You can see here that there is an abscess, which is a biliary abscess. This patient had been successfully transplanted at the end. But this is just to remind you, please, please, please never send a patient with vascular malformations to embolization of arteriovenous malformation, because it is ineffective for improving the shunt, and it can lead to this very, very severe complication per se. Angio-CT is what we can use to see better where malformation can be located, not only in the liver, but in other organs, and you can use more modern techniques like photon counting or MIP to have much better visualization. Going to the treatment, unfortunately, we do not have much yet. We do a symptomatic treatment. The iron supplementation is important, local therapy of epistaxis, treatment, endovascular treatment of the lung and cerebral malformation. We can do medical therapy of pulmonary hypertension and portal hypertension. And if the patient has a heart failure without fixed resistance in the pulmonary artery, we can think about liver transplantation in case we cannot do much. Recent evidence, however, showed some effectiveness of bevacizumab, which is an anti-VEGF receptor A, and I will show you just a couple of data on this. This is a randomized controlled trial, very small. Of course, this is a very rare disease, so there is not big trials on that, but showing a reduction of transfusions in patients undergoing courses of bevacizumab for epistaxis. And additionally, there is some data in patients with large liver vascular malformation, so grade 3 or 4 according to Buscarini. And there is even some evidence showing that you can spare liver transplantation. And due to this, some authors and friends in the reference center for HHT tried in larger cohorts, and you can see here that if you apply bevacizumab for a sufficient amount of time, there is in a decent number of patients an improved cardiac output with reduced episodes of epistaxis. And therefore, the current recommendations on HHT that have been published in 2020 recommend in 2 points, in 2 moments of the natural history, to try bevacizumab. One is GI bleeding, so severe GI bleeding, and the second one is high output cardiac failure due to liver malformation that has failed to respond sufficiently to first-line management. They are not very strong recommendations because bevacizumab has side effects and it can lead to thrombosis and other problems, but still, this is at the moment what we have. The future looks brighter, and there are several drugs that are involved in the pathway of angiogenesis that are being developed for HHT. So I'm relatively sure that in the next 5 years, we will see some of them coming to the clinical practice, but at the moment, again, we don't have much. Liver transplantation is difficult in this population, but is successful, and long-term survival is excellent. So you can see 82% at 10 years. And in the US, there is even a mild exception for these specific patients when you have acute biliary necrosis or when you have intractable heart failure waiting for liver intractable heart failure despite having tried the medical therapy as much as possible. So think about it early. These cases need to be discussed very in detail interdisciplinary, but I think a chance should be given to this patient whenever possible. These are my take-home messages on this part. Please be systematic in your screening or refer the patient to centers that have experience. These patients not only have the bleeding as problem, they also have thrombosis, stroke, infection, so think about it. Liver involvement is able to be screened with ultrasound. Bevacizumab should be considered at the right moment, and liver transplantation should be considered without waiting too long, especially in our setting with such a long waiting time. And with this, I thank you very much for your attention.
Yes, Annalisa, thank you so much for this really outstanding presentation. I'm sure there are the one or the other questions.
The beauty of rare diseases is that nobody has ever questions.
wait, no, Annalisa, I'll ask you a question. Yeah. I sometimes find it difficult, but maybe that's just I'm a surgeon. When you have these patients with vascular malformations, you can't, or I always have the feeling you can't go for the classic signs of what a malignant liver lesion looks like. So what you recommend here, do you always say if you have a patient with a vascular malformation, send him or her to a clinic that has more experience, or would you say do a biopsy or don't do a biopsy?
So if the lesion is hyperintensity 1 on MRI, this is in the literature much more associated to malignancy than the other aspects. So if it is hyperintense, these are usually FNH-like and not dangerous, but these other lesions should be biopsied. This is the agreement in the literature. So with liver biopsy, you can have an idea of the histology, and you can see whether it is an adenoma that is not yet beta-catenin mutated or whatever, or something else, or even hepatocellular carcinoma that in Abernethy in particular is described. So you cannot rely, unfortunately, on the standard aspect. It's not the same as a liver with a portal venous flow. So it's here we only have the artery and the outflow, and no portal vein. So it's important. In HHT is different. In HHT we have the portal vein, and according to the literature, you can use the same aspects as in a non-hyperarterialized liver. But as for the other situations, so the Abernethy is really difficult because it's completely deprived of the portal venous aspect.
And do you in these patients, like patients, for example, with cirrhosis, do you recommend a lifelong screening or not?
You mean if you are not treating them elsewhere? You mean for the Abernethy or for?
Yeah, if you have a liver lesion and it looks okay, and you say the risk of transformation to malignancy is low, would you screen these, or what do you do with these patients?
Yeah, so you keep them in follow-up, of course, not only for the liver lesions, but also because they can develop symptoms. So they can develop encephalopathy, which is indeed later in life more common. And we had some cases in the past showing encephalopathy very late, and we transplanted one years ago. I don't know if you remember, who developed chronic encephalopathy very late in life. He was more than 50, and before it was not diagnosed of the disease because he was asymptomatic. So I think at least yearly or every 2 years for the clinical aspect, as a follow-up is needed, and I would at least do an imaging with ultrasound every year, honestly. There is no indication to do a classical HCC screening every 6 months, but an imaging assessment every year, I think it makes a lot of sense.
Good. Annalisa, I'm sure, I mean, I would also have had the one or the other question, but it's 1:30 and people, I think, will go to the Tumor Board conference.
Okay. Have a good
so
day.
thank you again. Thanks so much. Yeah, have a nice day.